Welcome to the WebMD Health Discovered podcast. I'm Dr. Neha Bartak, WebMD's Chief Physician Editor for Health and Lifestyle Medicine. Every year in the United States, close to 800,000 people have a stroke, and over 600,000 of these people have a first stroke. Stroke is the leading cause of long-term disability. What are some of the key risk factors for stroke? How does high blood pressure play a role in stroke? And what does the road to recovery after a stroke look like? Today, we'll take a step-by-step approach to stroke, from awareness of stroke risks, including how the menopause transition plays a part, prevention, stroke management, post-stroke care, and recovery. But first, let me introduce our guests, Doctors Aisha and Dean Sherzai. Dr. Aisha Sherzai is trained in preventive medicine and neurology. She's recently enrolled in a PhD program for women's leadership. Dr. Dean Sherzai is a behavioral neurologist and neuroscientist whose life has been dedicated to behavioral change models at the community and population level. He is trained in neurology and has received a PhD in healthcare leadership focused on community empowerment. Doctors Aisha and Dean Sherzai are the hosts of Your Brain On podcast, a new podcast about the neuroscience of everything. Welcome to the WebMD Health Discovered podcast, Doctors Aisha and Dean Sherzai.
Thank you so much for having us, Neha. We're so excited to be here with you.
Thank you.
So I am really interested in getting into our discussion for today around stroke. But before we dig in, I'd love to hear more about your own personal health discovery, your joint aha moment around the work you do in neurology and community engagement.
We met about 21 years ago, and our first conversation was about public health. And that's how we actually started our first conversation about public health and dementia and all these neurological diseases.
More exciting than that, the conversation.
Yes.
It revolved around the importance of public health and what we can do.
Correct. So that made us aware and receptive to those kind of signals. And in the clinic, for the next few years, every patient we would see, we would have an awareness of what's going on. Are we making an impact? Are we really truly touching the underlying phenomenon that leads to disease? And our aha moment actually almost simultaneously was we saw patients that were not responding, especially the ones that were most at risk.
I'd love to take that conversation that you're having in the community and focus it in on stroke. But I imagine that it's a very similar conversation when you're talking about prevention of a variety of neurologic conditions. So just honing in on stroke, can you help us first define what are some of the terms that our patients hear about? So stroke, mini stroke, TIA. Let's start there.
That's right. Yes. So stroke sounds like a very scary word, and it is a pretty scary condition to see because it happens all of a sudden. Patients are usually not aware. And unfortunately, the way it presents itself also poses the risk of it being missed most often. And that is also one of the main reasons why organizations such as the American Academy of Neurology and American Heart Association are highlighting different acronyms and jingos and things for people to remember to identify these devastating conditions. And so when a stroke happens, people suddenly start having neurological deficits. And depending on what part of the brain is affected, it could be things like language deficiencies, it could be paralysis, it could be sensory changes, or any of our senses being affected, whether it's our vision, balance, so on and so forth. And so the different words that are common in our community as far as stroke is concerned, we have the word stroke, and then there's the word TIA, which stands for transient ischemic attack. Sometimes that is usually interchangeable with a mini stroke. So there's a major stroke and a mini stroke. And TIAs are usually ones that last for at least 20 minutes or as long as 24 hours, but they don't have long-lasting neurological deficits, which means that people develop symptoms of stroke, but then they go away. And most of them should go away within 24 hours. And by neurological definitions, they don't leave any damage in the brain. And then there are different types of strokes. You have the ischemic stroke and you have a hemorrhagic stroke. Ischemic stroke is the type of stroke that is associated with impediment to the flow of blood in a blood vessels in the brain because of the presence of a clot or any constriction. And the area of the brain that needs the blood and the oxygen essentially dies. The neurons in that region of the brain die because they don't get enough oxygen and nutrition. And then there's hemorrhagic stroke, which essentially means that there is a bursting of an artery in the brain, and there's a lot of bleeding. And the manifestation of hemorrhagic stroke is damage to the brain cells because of the bleeding and because of the pressure that is built because of the space occupying capacity of the blood. So those are the terms that people usually hear related to strokes.
I really appreciate you helping us break down these definitions and really pointing us to a lot of the work that's being done so that people can think about recognizing these symptoms straight away and getting help as soon as possible. So, not necessarily waiting to find out what's going on. How do you have these community conversations before you even get to the prevention, that sort of that acute event? Like, if you see this, don't wait. Don't see if it will resolve. Just call 911. How are you having these conversations? What are you asking people to really think about? And what's that trigger to call 911?
I think, as Dean was mentioning earlier, the importance of public health. Once you see the impact of these kind of conversations where you're providing a level of health literacy to the public and to individuals who may not have any understanding of biology and physiology and medicine per se, the conversation actually starts at a very, very early stage. Every individual at any age should have a basic understanding of how their body functions and when to recognize that there's something going on. As you and I were having these conversations ahead of this podcast, the devastation that is caused by stroke is immense in the United States and around the world. The numbers are pretty scary. Every year, about 800,000 people experience a stroke, and it is the number one cause of disability in this country, which essentially means that people are left with these devastating effects for the rest of their life. And it's not just affecting them, but the burden of care on their caregivers, on their families, on their loved ones, on the society, on our economic system is very impactful and significant. So the conversation essentially starts at the level of just screening. Most of primary caregivers or general practitioners or any healthcare provider that has a point of contact in this society, anyone that is responsible at some level for the well-being of a community should have these conversations. And so as a neurologist, unfortunately, I'm always seeing individuals at the downstream effect when something bad has already happened. And so I never get a chance to speak with my patients about prevention as much as I should. People are never sent to a neurologist to talk about preventive neurology. So these conversations happen, and they should happen with medical students going in and visiting a patient for something else, or for general practitioners to bring it up. Or say even when somebody goes out into the community to talk about some of the risk factors of stroke, such as smoking. Someone who's in the Department of Public Health and is allowing for people to understand the impact of smoking cessation on their health should be able to speak about stroke prevention and identification of symptoms. There's good work that is being done by the American Heart Association and American Academy of Neurology, whether they're advertisements on the streets. You might have actually seen some billboards, and their acronyms such as ACT FAST. FAST stands for face. A is for arm. When you see somebody's arm, you test both arms, and if one of them is not functioning as well as the other, that's when you get concerned. S stands for speech. When you hear someone having garbled speech, or if they don't understand you, or if they can't produce good words. And T, it stands for time to call 911. So these acronyms, these billboards, these public health messaging are really changing our perspective about stroke, and we should all be involved in it as much as we can.
For the vast majority of people, when we think about stroke, we're thinking about a preventable condition. So what are the major things that we should be thinking about in terms of risk modification?
So there's a good way to organize this. There are the primary things that we can do long term, and then there's the acute things that we need to do, such as the medical conditions that affect this. We're talking about blood pressure, cholesterol, diabetes, obesity, all these things that can be affected because blood pressure is the main risk factor at so many levels. It damages the most important real estate in the planet, the endothelial lining. As a neurologist, we would say it's the neural system, but it's okay. The endothelial lining still feeds that neural system. So endothelial lining is damaged by blood pressure, and it's critical to address that. If somebody even suspects that they might have blood pressure, you should check it regularly to see patterns, and then that should be addressed acutely with medicine. Diabetes, pre-diabetes. We didn't even think about pre-diabetes previously. We did a review with NHANES, and we saw that even pre-diabetics had cognitive decline at a younger age, and that should be addressed as fast as possible. Cholesterol, specifically LDL, at this point, to the best of our knowledge, that's how we approach things, not perfection of knowledge, but to the best of our knowledge, LDL has a very, very strong correlation with stroke and dementias and other diseases. That must be addressed. Long term, it's lifestyle variables that affect these endpoint diseases as well as other things. We're talking about nutrition, we're talking about exercise, we're talking about stress, which nobody really has a good handle on. We're talking about sleep. There's a reason you're paralyzed 1/3 of your life. That's a sacrifice because it is literally that important. And then, of course, lastly, which is mental activity. Mental activity is the real estate that you reclaim on a daily basis with how you challenge your brain. Not necessarily with Sudoku, but with things like musical instruments and dancing and learning and all these things. So those are the two levels of approach that are critical. They're well definable, and we can really spread this to the general population.
And so I think that's really important. And thank you so much for really helping us think about it in this categorization or this way. In terms of the risks for the major types of stroke that you were talking about, from the ischemic, more of that sort of the blockage type of stroke versus the hemorrhagic, the bleeding type of stroke, in terms of those particular endpoints, are any of these modifiable risk factors more likely to lead you to one versus the other? How do you think about that?
That's a great question. So, when you differentiate between ischemic and hemorrhagic strokes, the majority of strokes are ischemic. And like I said earlier, they're caused by a blockage in an artery leading to the brain. And the risk factors may differ a little bit for them. The rest of the strokes are hemorrhagic, which is about 15 to 20% of all strokes. Ischemic strokes tend to happen more during midlife and later life. It has been associated with cumulative damage to the endothelium and to our cardiovascular system. So, risk factors such as high blood pressure, untreated diabetes, long term untreated high LDL cholesterol that damages the inner linings of the arteries and make it stiff can result in blockage to the arteries. So, ischemic strokes usually happen during a prolonged period of time of our cardiovascular system being exposed to these assaults. And even food can be an assault, or lack of exercise can be an assault. Hemorrhagic strokes, on the other hand, is more associated with conditions that can burst the wall of an artery. And they tend to happen at different stages of life, but it more happens in individuals who are younger. They can be related to, say, for example, high blood pressure that is extremely high and it goes up at a very fast rate. We tend to see hemorrhagic strokes in people who are under the influence of a medication that could increase blood pressure, or, for example, in situations where there is mechanical damage to the arteries. I've actually seen a lot of patients who have done a particular kind of an exercise that could twist their neck, or, say, for example, when they have a yoga pose that kind of hurts their neck, or unfortunately, some chiropractors doing very aggressive maneuvers to people's necks and that causing dissection and that leading to hemorrhagic strokes. It can also happen as a result of trauma to the head. Direct trauma to the arteries can lead to bursting of an artery, but it mostly is related to a sudden increase in blood pressure resulting in the bursting of these arteries. And that could be related to drugs, to specific conditions in the body that could raise the blood pressure, whether that could be hormonal or endocrine. So it just depends on what age group we're seeing. And as far as risk factors of hemorrhagic strokes are concerned, obviously the first one is blood pressure. It really does affect the volume of the blood seeping into the brain and into those closed spaces, as well as the health of the arteries in long run.
I'd love to pull in the menopause transition here. So, how does that fit in with traditional risk factors? And then does it become more of a risk factor as you go through that transition or your postmenopausal as it relates to ischemic strokes or hemorrhagic strokes?
I think that's a very good question. And that in itself is a very complex and a long conversation. And hopefully we can actually make time for that. But the gist of it is women who go through perimenopause and menopause do have an increased risk of ischemic stroke. That has been documented in multiple different studies. And the reason is that our hormones, specifically estrogen, plays a very important role in the pliability and the health of our arteries. And when that goes away, our arteries stiffen up and our chances of stroke doubles. Now, scientists have looked at multiple ways of addressing this. Unfortunately, hormone replacement therapy, we don't really have good data on it as of yet, but the trends show that hormone replacement therapy, if it started later during the journey of menopause, could increase the risk of stroke as well, and other cardiovascular diseases too. So timing matters. In one of the latest systematic reviews that was published a few years ago, I believe it was either 2020 or 2021, and they looked at multiple different cohorts in Sweden from Karolinska Institute, and they found out that the timing of starting hormone replacement therapy is incredibly important. And it seems that if it's started early, 1 to 5 years of menopause, it could be protective. But obviously, this depends on the patient and their individual risk factors, and it's a conversation to have. So, what does this mean for us, and what are the implications? I think every woman going through perimenopause and menopause should have a conversation with their general practitioner and a neurologist, if possible, to address their risk factors and see if they're good candidates for hormone replacement therapy.
So we've talked about, really, if we're thinking about this as a relay race, the prevention aspects, the early identification aspects. So let's move on to then management and potential post-stroke care. If you are in a situation or taking care of someone that suffered from a stroke, what does that look like?
First and the foremost thing is getting the patient to the hospital and to emergency room as soon as possible. Time is brain. Once they're there, if it is an ischemic stroke, they are going to be exposed to a number of different possibilities depending on the timing of the stroke, the person's risk factors, their age, their gender, so on and so forth. So the first thing that is provided for someone with an ischemic stroke is thrombolytic therapy, and that is administration of drugs like TPA, which stands for tissue plasminogen activator. It's a clot buster, essentially, and it is given within the first 4.5-hour window of having a stroke to dissolve the clot and restore blood flow. In situations where that's not possible, endovascular procedures are offered. And those are procedures where you basically physically go inside the artery and take out the clot. And that is reserved for the first 24 hours after someone has a stroke. For hemorrhagic strokes, when there is a lot of blood into the brain, the focus is on blood pressure management and surgical intervention to either get rid of the blood from the brain or to manage the pressure inside it, or both. So it's a multifaceted approach of addressing multiple risk factors at the same time to preserve as many brain cells as possible.
I'd also like to bring it full circle to what you said earlier as well, Dean, in terms of after these interventions, getting back to some of the lifestyle interventions, thinking about stress, because this is genuinely a very stressful situation in most cases. So how do you then have that conversation to bring people back to optimizing themselves after a stroke?
Absolutely. It's a very, very important period. You have to take the patient in mind, and there can't be any judgment. A lot of the patients have depression that's intrinsic to the disease, not a secondary consequence. We know that there's parts of the brain affected that affect mood and motivation and energy levels. So that should be addressed. And with that addressed and with that taken into consideration and knowing the resource at home, then physical therapy, speech therapy, cognitive therapy, all these things must be instituted. At the same time, the kind of lifestyle intervention should be taking in place that is doable in their home and their life, which means nutrition and exercise and stress management techniques and cognitive activity that really can be inculcated into their lives in small, incremental, meaningful ways. A lot of times we throw recipes at people and these recipes don't even mean anything to them. That we have to become a little more nuanced. The 21st century is about nuance. It's about understanding complexity of humanity and addressing it because we're there now. So knowing what the person's background is, their proclivities and tendencies, giving them the resources, the nutritional advice, the recipes that are relevant to them, as well as exercises that can be done, that can be repeated, and they have the resources to do them. And if we don't take that into consideration, we're literally creating compounded failure. And that's where we're adamant, and we keep talking about this, that the medical field has to become comfortable with the complexity of dispensing lifestyle and preventive measures that are relevant to each individual's circumstances.
Yeah, I think that's so beautifully said. I know that in my own cultural tradition, if you think about or prescribe a Mediterranean diet, you're going to get a lot of blank faces and not a lot of uptake of that intervention. So I love the point about even these interventions are very personalized. This is really in the realm of personalized medicine, even when you're thinking about lifestyle, because it is specifically which of these interventions are going to be personalized to you, to your family. But hopefully, there is a community of people, or you want to help as a healthcare professional identify a community of people that can help afterwards as well. I'd love to just in our last few minutes together talk about any research or emerging trends that you're seeing or that you're working on when it comes to stroke prevention and treatment. I'm specifically thinking about articles that I read recently about air pollution, microplastic pollution that might be playing a role, particularly in regions that are overburdened just because of socioeconomic status that are very highly exposed to air pollution and other sort of toxic environmental exposure. So just curious what else you think we should be thinking about or what you're working on.
I love that question. And it's a question that addresses how we approach data in the 21st century. Often people approach data in a binary fashion yes, no, 100%, 0%. It's not that. Even knowledge and science is not that. We usually don't have causal pathways that lead from A to B. We don't have causality between smoking and cancer because I don't think we can do clinical trials where we see if we can cause cancer. So we really have to be comfortable with how we approach data. And speaking to that, some of the new data is alarming, yet still not well elucidated, such as microplastics. The ubiquity of microplastics is kind of alarming, and it should be alarming, and it should stay at that level, alarming. And we should study it more, seeing how it's related and correlated, strength of correlation with different diseases, while taking into account confounds, other things that could be truly affecting and not microplastics, or it's microplastics. Same thing with pollutants and the size of the pollutants. There are ubiquitous variables that vary from place to place, from mile to mile. Now, we know that along that line, population diseases differ. We know that diseases differ by zip code, but there are many other things that vary. So I think these are very important factors that we should keep in our radar. We should explore in its complexity and not negate it, but also don't jump in the camp as a binary outcome. Yep, everything is microplastics or this or that. I think the most important thing we can do as scientists is to help people and ourselves in our own community be comfortable with the spectrum of data and how we approach each at each level.
That's very well said. Living with uncertainty on that spectrum of, I think it's very hard to say we'll ever get to certainty, but living in that spectrum and just using as much information as we possibly can to make the best choices we possibly can. So I really appreciate that. I'd love to close the episode with giving space to you both. If you have bite-sized action items, tips that you can share with our audience that someone could start working on today.
Movement matters. When you look at communities that are healthy, and well studied, meaning they've looked at all variables, movement was the thing that mattered the most. Start incorporating movement into your daily activities. Stand up and watch a movie and make that part of your life. This one show every night is going to be my movement. It doesn't have to be a HIIT session in a gym. It doesn't have to be the New York Marathon. That's fantastic if you do it. But it can be a marathon that you do half an hour a day for 6 months. And that impact is massive. We're talking about studies that have shown repeatedly that brisk walking has a profound effect on your brain health, ultimately. So that's a really useful piece of advice I give to my patients.
You know, one of the easiest ways of controlling what goes into your body as far as food is concerned is to learn how to cook. I encourage a lot of my patients and community members to learn how to make one or two of their favorite recipes, because when you're cooking, you have more control over the kind of ingredients that go into it. You have control over the kind of fats go into it, the spices, the amount of salt, which all matter. It makes it delicious. It makes it healthy. And you also prevent using things that may potentially damage your arteries and your heart and your brain. So learning how to cook is an easy way to include healthy foods in your dietary pattern.
Thank you so much. We've talked with doctors Aisha and Dean Sherzai about the entire spectrum of stroke, from prevention to post-stroke recovery. To find out more information about doctors Aisha and Dean Sherzai, visit thebraindocs.com or check out their podcast, Your Brain On. And we'll have all this information about how to connect with them linked in our show notes. Thank you so much for listening. Please take a moment to follow, rate, and review this podcast on your favorite listening platform. If you'd like to send me an email about topics you're interested in or questions for future guests, please send me a note at webmdpodcast@webmd.net. This is Dr. Neha Pathak for the WebMD Health Discovered podcast.